Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
This piece is presented by Dr. Glenn Murphy. He's currently the Jeffrey S. Vender Chair of Anesthesiology Research and Education and Director of Cardiac Anesthesia and Clinical Research at North Shore University Health System, a hospital affiliated with the University of Chicago, Pritzker School of Medicine.
Well, I thank everyone for coming today. We've heard a lot about ERAS and we've heard about minimizing the use of opioids, which I think is very important. But I think we as clinicians tend to think of all opioids as being equal. And I think there's a lot of differences between the opioids we use. And I think methadone is a very unique opioid that we can use in our clinical practice that has some advantages, particularly in the era of ERAS. These are my conflicts of interest. Again, we heard over and over again, a significant percentage of our patients still suffer from pain despite this use of multimodal analgesia in the postoperative period. And we also heard it can lead to acute events in the postoperative period. And more importantly, studies in the past decade have shown that patients who have a lot of pain in the postoperative period are at significantly higher risk of developing chronic post-surgical pain. What the basic main advantage of methadone is very long acting. So if you look at the elimination half-life, it's 24 to 36 hours. It also comes on very quickly. People think of slow-acting drugs being slow in onset. It comes on quick and it lasts a long time. And instead of those peaks and valleys in pain management, where someone hurts a little bit, they ask for pain medication, they get it, or they press the PCA button, you have a very stable level of methadone over a long period of time, so patients stay consistently comfortable. There are a number of other advantages of methadone. It has NMDA blocking properties that are almost as potent as what you see with ketamine. And that can prevent hyperalgesia, chronic pain intolerance. It prevents the reuptake of norepinephrine and serotonin in the brain, so it produces a mood-elevating effect. And again, we also know that antidepressants actually produce a pain-relieving effect. It simplifies pain management. We give one dose at the beginning of the operation, and that's all you have to do. You're not titrating opioids. You're not putting them on a PCA afterwards. In fact, some studies have shown that it's more effective than using an epidural in controlling pain after surgery. And it's a very low-cost drug. There have been 20 clinical trials. Most of these clinical trials have been prospective, randomized, double-blinded trials looking at methadone in the perioperative period, and basically looked at a whole variety of different surgical populations. And if you look at these trials, they all have almost all the studies have shown that they result in about a 50% reduction in postoperative pain need for analgesics postoperatively, 30 to 50% reductions in postoperative pain. If you look at the risk of adverse complications such as respiratory depression and things like that, they are not increased in the group that gets methadone. They've also shown in several studies recently that there's a lower risk of nausea and vomiting. Patient satisfaction is increased. And in 3 recent clinical trials, when they followed these people for months after surgery, had significantly lower pain afterwards. And I think that's where the biggest advantage of this drug may be. When you follow these people after they leave the hospital, they do significantly better. And why that is, whether it's NMDA blocking properties and mood elevating effects, it's not clear, but there seems to be something really here. I'd just like to point to 2 of the most recent studies, because again, a lot of these studies, this comes out of Evan Karish's group, who's done a lot of work in this. Evan Karish describes methadone as an opioid-sparing opioid and thinks it should be used as part of our multimodal treatment that we use for our patients to control pain after surgery. In this study, it was a double-blind study. It's a pilot study. They only looked at 60 patients. They looked at patients getting 0.1 milligram per kilogram, 0.15 milligrams per kilogram of methadone, or standard intraoperative opioids. They looked at postoperative pain scores and analgesic requirements. What was really good about this study is they sent the patients home with pain journals for 30 days to record what their pain was, how much opioid pain medication they needed in those first 30 postoperative days, and looked at functional recovery. What they found While in the hospital, analgesic use was reduced by about 75%. Pain scores were less in their patients. But most importantly, when they looked at these patients for the 30 days after surgery, the patients who got methadone 0.15 milligrams per kilogram had a 50% reduction in need for opioid pain medications, and pain scores were significantly less in this group. We did another study. Methadone is most commonly used in this country in patients undergoing complex spine surgery. So we did a study. 120 patients were randomized to get 0.2 milligrams per kilogram of methadone at the start of surgery or 2 milligrams of hydromorphone at the end of the surgery. And then we looked at pain scores, analgesic requirements, patient satisfaction with pain management. And then we looked for a variety of opioid-related side effects after surgery. What we found was postoperative PCA hydromorphone requirements were reduced by about 60%. The need for oral pain medication was reduced by about 40%. Pain scores were reduced by about 30 to 50%. And these are all during the first 3 days after surgery. And we actually quantified overall satisfaction with pain management. Patients were much happier with their pain management. This has been shown in 2 other studies that assess patient satisfaction with pain management. Patients are much more pleased with their pain management if they get a dose of methadone. Again, in this era of ERAS, that's something that's, I think, very important in recovery. When we looked for all the adverse complications for surgery, we saw none. In fact, we followed this patient population for a year after surgery. We found 1 in 3 months after surgery, patients reported significantly lower pain scores and significantly decreased need for oral opioid medication. So again, if we're looking at this opioid epidemic, what can we use to reduce this need for postoperative pain? Methadone is one of those agents I think we can use for that. And I saw this yesterday as I was flying in the plane here. A study in bariatric patients was performed. They randomized to methadone or standard opioids. They found very similar results. Basically lower pain scores, lower analgesic requirements, significantly lower nausea and vomiting scores, significantly increased patient satisfaction. In 3 months after surgery, when they examined them for chronic post-surgical pain, they had significantly reduced pain scores. So very interesting findings, and I think it fits in all with what we're trying to do in our ERAS protocols. So what do I do in my clinical practice for using methadone? You can give a single dose of induction of anesthesia, and most of these patients, you don't have to give anything else afterwards. For procedures that are very painful, I'll typically give 20 milligrams at the start of the operation. And for people who are older, have physiologic reserve, I'll typically give a dose of 10 to 15 milligrams. And if patients get to the recovery room and they have pain, we'll typically titrate small boluses of 3 to 5 milligrams of methadone until the patients get comfortable. What's been shown in our investigation and several others, once you get them comfortable in the PACU, many of these patients require no other pain medication for the rest of their hospitalization. And now, with this data that's come out recently from Evan Karish's group, even in ambulatory surgical patients, giving these patients a dose of 9 to 10 milligrams of methadone in ambulatory surgical patients significantly enhances the recovery in the hospital and probably has an important beneficial effect after their discharge. So this is summarizing a lot of data, but I hope there are a number of studies that are underway right now looking at methadone in the perioperative period. So it's something I hope you'll read the literature on and consider use in your practice. Thank you.
Nick Majerison here. Have you got yourself onto EBPOM.org yet? If not, you might not be aware, EBPOM Chicago tickets are free for a limited period only. Go now to EBPOM.org. Evidence-based perioperative medicine. EBPOM.org.